So, continuing on with what Lori talked about with the culture of quality and what quality means, we'll dig more into that. But one of the things we also want to really emphasize is that all of you represent these amazing partnerships. And even though we will spend a lot of time this week talking about things that are going wrong and things that could be improved, it's also really important to acknowledge. So, continuing on with what Lori talked about with the culture of quality and what quality means, we'll dig more into that. But one of the things we also want to really emphasize is that all of you represent these amazing partnerships. And even though we will spend a lot of time this week talking about things that are going wrong and things that could be improved, it's also really important to acknowledge and think about all the things that are going right in your institutions. That there are amazing doctors and nurses and people doing things that the doctors here might not be able to keep up with. I was talking to Dr. Rajiv in Nepal, and he is doing 10 things at once. I'm like, is that even your job? But, like everything from logistics to cars to is there electricity? There are things, you are multitasking all the time. So we also need to acknowledge that all of these things that are going wonderfully well and the strengths that are in low resource settings. And because when you have hospitals operating in low resource settings, you do have to make things work. So how do we talk about it? How do we use that to make things better? So continuing on with what Lori talked about with the culture of quality and what quality means, we'll dig more into that. But one of the things we also want to really emphasize is that all of you represent these amazing partnerships. And even though we will spend a lot of time this week talking about things that are going wrong and things that could be improved, it's also really important to acknowledge and think about all the things that are going right in your institutions. That there are amazing doctors and nurses and people doing things that the doctors here might not be able to keep up with. I was talking to Dr. Rajiv in Nepal, and he is doing 10 things at once. I'm like, is that even your job? But, like everything from logistics to cars to is there electricity? There are things, you are multitasking all the time. So we also need to acknowledge that all of these things that are going wonderfully well and the strengths that are in low resource settings. And because when you have hospitals operating in low resource settings, you do have to make things work. So how do we talk about it? How do we use that to make things better? So we'll briefly talk about an example, a case study of what went right. We will talk so much about what's going wrong and what could be better. Let's start from what is going right. So on the workbook of section of your white packets, on page 4 is this case study. If in your group you would want to spend around 5 minutes reading through this case study and think about, as you're reading through it, what is going right in this case study. So would anyone like to share what they think went right in this situation?
The first thing that is they managed to call the train person birth attendant.
So calling the birth attendant was the first step in that. So, anyone else?
I think the biggest thing which they had done over here is the training to the training which was given to the traditional birth attendant, so that they were able to recognize that the danger of a retained placenta. That's an important thing. And then they were also given, I think they had been trained to assign duties. So in this particular case, the woman's brother was sent to arrange the car, and then she had also informed the hospital beforehand only, so that the hospital stayed ready, so that when the patient comes in, everything's ready, the IV drip, the oxytocin. So I think the training which they had given a very good training that which they had given to the traditional birth, and that's the thing which had made a big change over here.
Yeah, that's great. Greg, did you have something to add? Sorry. Okay. Yep, doctor.
Probably additional things what we are
I think it's really important to emphasize here the trust that this family has in both the traditional healthcare assistant as well as the health facility they were sent to, and that they took all of the recommendations at face value and did exactly what they were advised to do, which we can hopefully assume is also a trust that's present in the larger community, which is what made all of this possible.
That's great. Greg? So the idea that the woman knows to call a traditional birth attendant, which goes with what we were saying about, there's this cluster of things that need to happen for some of these things to go right. From how does the patient access the service if they don't even know they should, being the first step. So, yeah, anything else to add to this case? So for some of the things was, first of all, is the recognition of the danger, that the birth attendant knew that something was wrong and that it was not within her scope of practice to do something about it and that it need to be referred to. I think there's a lot of training and recognition of that because you don't want someone to be like, oh, I know how to deal with it. They might not, especially when it's a clinical thing and they need to go to the hospital. And decision to evacuate from the village health center. And first of all, that there was a village health center is that's not always there. That there was transportation. Whenever I read this, I think about in Nepal where I'm like, first of all, is there a vehicle? Second of all, there's no addresses. And flagging down the vehicle, and this happens especially in the cities where the roads are so small that you can't get an ambulance in. So where do you meet the ambulance? And that happens all the time. Is it takes a couple hours, even in a city, for the ambulance to get there. And in a village, if it's monsoon, it might not even be possible, which happens quite often. And then the reception at healthcare, that they were ready, that they had a protocol and they actually followed it. And they knew exactly who was coming in and that they knew what to do for it. And they were anticipating, and that they actually had time to get ready for that, which is a huge thing, to have time and people who can prepare for something instead of just dealing with what's coming at you. And emergency care, correct technical care. And Lori talked about the many dimensions of care, and one of that is that the doctor or the EMT at the health center knew exactly what to do for this. You need that technical aspect as well. And the good interpersonal communication is also really important. And you can really see that in the end of the case where after she's done and she's safe, the woman and the baby are taken care of. That and she's breastfeeding, which is an important part of that birthing process and connecting with the baby. So, when we're thinking about the dimensions of quality, which Lori will talk a lot more about, is what is important to the mother is having the baby in her arm and really recovering from that process. So all of that are things that goes right. And then if you think back and you put yourself in the woman's role who went through this ordeal, or the brother's role, or the family, what do you think they'll say when they go home after all of this is done? Sorry? They will be satisfied. And they won't talk about, the quality of this hospital and the processes worked really well. They will talk about it was a miracle that the baby survived, that that the doctor saved my life for the baby's life. They'll talk about how well it went. And that's the point is, a lot of times what we do with quality improvement is invisible. And that's the point, is it makes the process go through. And a lot of these things, it's not a miracle. I mean, there might have been some of that higher power involved, but it's us doing these. Someone went through and saw this as a problem and trained the birth attendant, made sure all these things in. Maybe it didn't happen in 1 year. Maybe it took 10 years, and this was the first time that this actually kind of happened right. And someone is in an office going, yes, finally, you know. And so it took a lot of work to make this miracle happen, but that is the work of everyone working within the health system, and that's our job. So, and that is why I love quality improvement, because it is making these things happen in a daily basis. So next, what I would like us to spend about 10 minutes doing is talking about things that are going right in your health systems, in your organizations, because things are going right. What are the miracles? What are things that you're like, this worked well? These are things that we are doing that maybe it was just one case, maybe it was a system. So if you'd like to spend a couple minutes talking within a group, and then we'll come back and share with a bigger group, because I think we can learn from that too. And that's why as we go on, we'll share a lot of these stories, because we can learn so much from each other. So let's come back together as a big group. And would anyone like to share some of any stories about what is going right in your workplace? Any strengths that you want to highlight?
So before what went right, I was telling them what went wrong. So Tibetan, we were refugees and we were not known to. Back in Tibet, it's a play to and very clean atmosphere, not known to many infectious diseases. Later, they came into India and known to many infectious diseases like tuberculosis. And in early 1960s and late 50s, there were so many Tibetan who died of tuberculosis. And now we at the Delhi hospital.
You need to turn right into the mic. It's coming out of you. Oh. Okay, actually, I'll just do this.
Yeah, it's okay. It's okay. Yeah, so I was talking about the tuberculosis burden in Tibetan refugees in early 60s and late 50s, and now our hospital has reached like treatment cure rate of 100%. So that's went right. Mm-hmm. Yeah, thank you.
That's amazing, and I mean, even by what people use Western standards as like this is how it should be, but that's something even at the hospitals here should be emulating, and that's there's a lot we can learn from in hospitals here from the hospitals in other places. So thank you for sharing. That's really great. Anyone else would like to share? We'll pass the mic around.
We ran out of time. I didn't get a chance to share this, but after the earthquake in Haiti, there was a horrendous outbreak of cholera. Mm-hmm. And at the time, we were putting in a clean water distribution system in a village that we work with. And it was just incredible to see the low incidence of cholera in that village, where surrounding villages were just, people were dying left and right from cholera. And it was just such a simple process to do this that had such a tremendous impact on the outcome of that disease.
Yeah, definitely. And that it's been interesting to see that example, and then the recent earthquake in Nepal, and trying to learn from the Haiti example. And I think, cross my fingers, there hasn't been a big outbreak of cholera as people had anticipated. I think it's because of some of these interventions. Okay. Anyone else? Okay. I think we'll hear more stories. Oh, is there one back there? Sure.
Very simple one. I don't know whether you like it or not, but I thought I should share. For example, in the middle of 1970s, our hospital, when we started the immunization program, people hardly respond because their awareness on the immunization program is very less, and parents, they are scared of the injection. Because of the immunization, when they get the injection, due to some side effect, all those parents are scared. And we need to educate them. It's very difficult and people don't turn out. So what we do, our hospital has done in the past is that we have given them sugar and milk powder as an incentive. And at that time, people, they are quite poor. And because of the sugar and the milk powder, they turn up there. And we keep on, educating them. And later on, because of the awareness of all those things, now we didn't have to give any sugar or milk powder, but they all come because they all are educated. Awareness is good. Now, the immunization, at that time, there are many polio cases are there. Now you don't find any polio cases in Tibetan community. The immunization program coverage is in the Tibetan community is almost, I think I can say 100%. So this is what went right.
No, that's great. Definitely, the immunization rates in Wisconsin is not 100%. So, which we will talk more about later on this week. And that's the idea: is that these what went right stories and things that institutions are doing right. There's a lot that Western countries can learn from hospitals in low resource settings, because especially all these surveillance programs that are so innovative and different ways that you're getting people to getting over their fears or misconceptions or different beliefs, and how do you move on. So I think I'm looking forward to that discussion. So we will move on to going back and talking about dimensions of quality, and then